Good morning, everyone. I think we have the last few that are coming on, so I just would like to start by welcoming everybody to our 5th day of our BMSW conference that we've had all week, which has just been absolutely wonderful for all those that have had the chance to be a part of it. So I just wanted to remind everybody that the reason we're doing BMSW is May is Bloodless Medicine and Surgery Awareness Month. And it's a nice month to just really reflect on everything that means. So just a little word on what BMSS has done, or Bloodless Medicine and Surgery Society is for this week and this month is meant to bring awareness. And we've done that through Bloodless Medicine Surgery Society, as well as we've organized through collaborating with SABM, which is the Society for Advanced Blood Management, and as well as the Malaysian Society of Patient Blood Management, MyPBM. So this is about bringing a superior form of healthcare in an organized way to bloodless medicine everywhere internationally. And so this is also something that we've collaborated and brought together on an international basis, which is really nice, because we've gotten to see how so many countries are doing this and bringing PBM, or patient blood management, right to the center of their cores. So the theme of our BMSW 2024 is Bloodless Care in Oncology and Palliative Care. So I do want to introduce my co-moderator this morning, Dr. Kenneth Inaku. And he is a consultant chemical pathologist in the University of Calabar Teaching Hospital, and that is in Calabar University, or out of the University for Nigeria, and he is also a member of BMSS.
Thank you very much, friend Iman. It's my pleasure to welcome all of you to today's program, Bloodless Medicine Surgery Week 2024. And it actually promises to be as interesting as the previous day. This is day 5, and we've had so much to help us improve our practice in offering the best of care. So it's my pleasure to welcome you. But today we are going to concentrate on 2 talks and the panel discussion. And number 1 will be keynote address on minimizing blood loss in cancer surgery for better outcomes. And then there will be a talk on bloodless care, complementing palliative care nursing. Then we also have the panel discussion. But first, some housekeeping. We want to note that all questions can be deposited at the Q&A, or placed at the Q&A section of this Zoom account, and it should be attended to. We also want to minimize chats during the talks so as not to distract the speakers and the audience. And also, the program is being streamed live on the BMSS YouTube channel in case anyone has difficulty to join the Zoom. So you can see the link in the chat as it will be posted, and then you can stream live as the program progresses. Or you can type Bloodless Medicine Surgery Society on YouTube to search for it, and you'll find us there live. So once again, you're welcome to today's program, and it promises to be very interesting. Sandy, please. Yeah, I think you're muted.
Thank you. Thank you very much, Kenneth. Also, before we introduce our first speaker, we'd like to mention that Dr. John Waters is going to be joining us tomorrow morning on Saturday with his presentation, and that is going to be blood salvage in oncology, fact versus myth. And that's going to be a very good presentation. So if everyone can join us for that, that would be wonderful. But right now, we're going to be introducing our first speaker, and that will be about minimizing blood loss in cancer surgery for better outcomes. And our speaker is going to be Dr. Christopher Simituo. And just wanted to let you know that his bio is very impressive. I'm going to go ahead and read that. So Christopher Simituo has a lot of initials after his name. FRCSI is one of them, FRCSED. But really the background for him is extensive, and it says that Dr. Christopher Simituo, his journey in medicine began with his foundational education in the University of Zambia, where he earned his Bachelor's of Science in Human Biology and later his Bachelor of Medicine and Surgery, which is MBCHB. His postgraduate studies at the esteemed Royal College of Surgeons in Ireland earned him the title of FRCSI, which is Fellow of the Royal College of Surgeons in Ireland. He is also a Fellow of the Royal College of Surgeons of Edinburgh in the UK and the College of Surgeons of East, Central, and Southern Africa, COSECSA. So over the years, Dr. Simituo has held significant positions, including serving as the medical superintendent of Kasama General Hospital and the provincial health director for Northern Province, Zambia. His clinical expertise spans across the managing multiple trauma patients, general surgical conditions, orthopedic surgery, urology, and obstetrics and gynecology. Dr. Simituo's commitment to education is evident through his past involvement in teaching at various institutions and his contributions to the College of Surgeons of East, Central, and Southern Africa, COSECSA. He has also played a pivotal role as an examiner, contributing to the University of Zambia and the School of Medicine for Copperbelt University. Currently, Dr. Simituo serves as a consultant surgeon at Luanshya, I hope I pronounced that right, Copper Mines, PLC, Zambia, where he manages a wide array of surgical conditions for the mine's employees and registered members. He has been providing bloodless medicine and surgery services since 1989. And as he plans for his retirement for formal employment, he has started a family private practice providing bloodless medical services. Certainly some great achievements, Dr. Simituo, and we're so glad that you can join us today. So I'd like to present this morning his talk again, Minimizing Blood Loss in Cancer Surgery for Better Outcomes. Dr. Simituo.
Thank you very much. Let me just share my screen. So we'll be discussing minimizing blood loss in cancer surgery. And just go backwards a bit. Thank you. So in this topic, we see that approximately 313 million surgical procedures are done worldwide each year. And in recent estimates show that 4.2 million people die within 30 days of surgery. This accounts for about 7.7% of all deaths globally. And estimates of post-operative complications and morbidity are even higher. Perioperative bleeding remains a major risk factor after surgery. This was in a paper which was presented by Mr. Shah from Oxford University in UK in 2020. Benign growths or lumps which develop in the body are usually well defined in the edges and hence are easier to remove during surgery. Whilst cancer growths or lumps, on the other hand, are normally ill-defined on the edges, and they tend to be glued to nearby structures and even directly infiltrate these structures. Therefore, surgery in cancerous growths is associated with increased bleeding. In the earlier presentations this week, it has been shown that most patients with cancer are anemic and have other associated morbidities. We'll see that the use of patient blood management strategies markedly reduces the need for blood transfusions as it focuses on preserving the patient's own blood, and this leads to better outcomes. What is patient blood management? I'm sure we've gone through this definition several times. Okay? It is a patient-centered, systematic, evidence-based approach to improve outcomes by managing and preserving a patient's own blood while promoting patient safety and empowerment. The focus is on patient safety and empowerment. The PBM has a 3-pillar, 9-head matrix of perioperative patient blood management. Understanding this will really guide on how we can manage patients quite well with minimizing blood loss. In the first pillar, where we need to optimize erythropoiesis, preoperatively, we see that we need to detect, investigate, and treat anemia, and treat iron deficiency anemia. Early this week, we had a lot of presentations on managing this. In my practice, I always manage patients with iron sucrose and erythropoietin, and they do very well. Still on the first pillar, intraoperatively, we need to schedule the surgical procedures quite well. We need to make sure that their blood is well optimized before we actually start the surgery. Still on the first pillar of optimizing erythropoiesis, we see that even after surgery, during the post-operative period, we still need to continue providing the iron sucrose or erythropoiesis to still continue building on their blood. And we need to be aware of the other drug interactions that the drug that they are receiving. In the second pillar, where we need to minimize blood loss and bleeding, okay? If we go back to the preoperative period, we need to make sure that we had a very good preoperative history, looking at all the other morbidities that needed to be sorted out before actually taking the patient to theater, and to develop a good risk stratification so that we manage the patient quite well. There are those patients who are on anticoagulants. We see which ones need to be stopped and which ones need to be continued. So this is very, very important in managing them. The second pillar in minimizing blood loss and bleeding intraoperatively. I think this is the main focus of our presentation. When we're operating, what do we do to minimize bleeding? A tourniquet has been found to be quite effective, especially in the surgery of the limbs. Okay? It is widely used in limb surgery, and it works very well. In my practice, where I used the tourniquet, I remember about 13 years ago, I had a nephew who had a fungating tumor in his left leg below the knee, quite big. He was in severe pain and foul smelling. He was initially being treated at our biggest hospital in Zambia, but because his hemoglobin was 8, the surgeons refused to operate on him until when they give him blood transfusion, which he refused. Until when I was informed, I called him to my hospital, and using tourniquet and under ketamine, we proceeded to do the amputation, above knee amputation. His hemoglobin came down from 8 to 6.5, but post-operatively, I made sure he received iron sucrase and erythropoietin. And with the time, the HB rose up to 10, then I referred him to a cancer hospital for chemotherapy. So a tourniquet can work quite well in reducing blood transfusion, in reducing bleeding while surgery, in surgery. The second one is cell salvage. In hospitals which have a cell salvage machine, it works very well. In cell salvage is a method of recovering blood from the surgical field, then taken through a machine for cleaning up, then pushed back to the patient. I'm sure Nigeria is doing so very well with Hemoclear, which they have now. A long time ago, I remember a similar way of cell salvage, more of auto transfusion in the late 80s when I was working in the countryside. We used to have a lot of where malaria was endemic. So young children had a lot of splenomegaly. So they would fall from trees, get a ruptured spleens, and would develop a primitive way of auto transfusion where I would get the blood from the abdomen. You get an empty bag of normal saline, put a gauze on top, pour the blood, the cloth will get in the blood goes to a blood pack, and that will be reinfused. Primitive, but now with advanced methods like Hemoclear, so which is quite working well for those centers which have this. Anesthetic conservation techniques. Anesthetists have had a lot of ways in which they improve to make sure that there is less bleeding during surgery. There is what is called permissive hypotension, which they know very well. There's what is called central neuraxia anesthesia. This is where the anesthetic technique play an important role in minimizing intraoperative blood loss. In central neuraxia blockade, where they blockade the subarachnoid and epidural anesthesia, this results in blockade of preganglionic sympathetic nerves fibers, hence arterial hypotension and the reduced peripheral nervous pressures. These result in less arterial and perhaps more noticeable, less venous oozing from the surgical side. The other way they use also is the ventilation strategies. So here they provide positive pressure ventilation with the minimal use of positive and expected pressure, and the lower tidal volumes have been advocated to reduce blood loss as it promotes venous return. So a lot of anesthetic techniques which are being used, which help the surgeon so there is less bleeding in the operating field. Meticulous surgery. I think it is very, very important for surgeons to know the anatomy of the area they are going to operate on. Once you know the anatomy, you know the pathology, you know where the blood vessels are, and you're careful when operating, you can make sure that the bleeding is less. Those who operate in the countryside who are not well experienced, they come across a lot of bleeding because they're not well versed with the anatomy and the pathology. So it's very important for the surgeon to know what he's doing, know the anatomy, know the pathology, develop a very good technique when carrying out surgery, and you can manage patients very well without much bleeding. The other areas are the new developments nowadays in surgery, areas with laparoscopic equipment. They are able to operate very well in a small field, contributing to less bleeding. And the latest advancements now with robotic surgery as well, it is really proving quite well in the centers which have this facility with less bleeding. The other final area, pharmacological agents. Commonly used is tranexamic acid. in my practice, I think in most of bigger operations, I always use tranexamic acid. In obstetrics, I always use tranexamic acid. It's cheap and it's affordable, and it's quite well used. There are other drugs which are also on the market which can be used as well. The second pillar also, during the post-operative period, we need to have this vigilance in monitoring bleeding. Always reviewing the patient. Make sure the patient's temperature is within normal range, and manage the anticoagulation in case there are some that you continued. We need to treat infection, make sure there's no infection by closely monitoring the patient quite well. In the third pillar, to harness and optimize physiological reserve of anemia. Here, the anesthetic will help us a lot during the pre-operative period, making sure that the patient has enough, the circulation is okay, the blood pressure is okay, the fluid management is okay, patient is not dehydrated. It's very important to make sure that the physiological status is actually quite well. Okay. And then we need to formulate specific, patient-specific plans to minimize in the plan that there's no blood loss post-operatively as well. Third pillar, look at also intraoperatively. Okay. The anesthetic will make sure that they are optimizing the cardiac output, monitoring the ventilation very well, and of course, a restrictive transfusion threshold by managing the blood volume very well, and with all the parameters put in place, one can make sure that the patient does not bleed much. During also post-operative period, the third pillar in harnessing and optimizing physiological reserve of anemia. Okay, just optimizing the anemia reserve. Okay, and minimizing oxygen consumption and avoiding unnecessary phlebotomy on the patients. The clinical practice points, we say that a multimodal strategy should be implemented to minimize bleeding. A good teamwork. In the operating theater, it is really important that the surgeon, before operating, work as a team. Let the assistant know what the surgeon is going to be doing. Let the scrub nurse know what the surgeon is going to be doing. Let the anesthetist know what the surgeon is going to be doing. Even the runner in the operating theater. If there is this good teamwork and well coordinated, you can actually enjoy the surgery, and there will be less bleeding because people will know what they're doing and assist each other in every step. It's very important to have a good preoperative assessment with review and management of the preoperative anemia, so that when the patient is going to theater, everything should be in place, and then things will be well. And again, lastly, the close collaboration between the anesthetist, the surgeons, theater nurses, the lab as well, getting the full results, hematological results, before you go to theater. I remember a long time ago, sometimes when operating, if we don't have doctor anesthetists, we have clinical anesthetists. So sometimes when you're operating, your eye is on the patient monitor. Your eye is halfway checking the blood pressure. If it's low, you ask the anesthetist, what is happening here? But with a good team, you find that you focus on the patient more. You know that the anesthetist is taking care of the patient quite well. So a good team is very, very important in managing this. What have we learned so far? The potential for major intraoperative blood loss remains a key concern for surgeons and anesthetists. Strategies to mitigate this, such as the identification and the management of anemia in patients, are very important. And these can be implemented early in the pre-operative phase. It is very important to adequately prepare the patient before taken to theater. During surgery, meticulous surgical techniques and local hemostasis are fundamental measures in the control of bleeding. Cell salvage is valuable if present. So I think the surgeon's expertise is very, very important. And I think in our settings, we find that most of the doctors who carry out surgery are really not qualified surgeons. They are general doctors who have been sent work in the countryside and do all these operations, and definitely take a lot of bleeding. So we need for cancer surgery, it needs to be reserved to properly qualified surgeons, properly trained, and who can make a good team to carry out these operations. Then the bleeding can be reduced. Tranexamic acid should be key, really, in most of the operations. And I haven't had any major difficulties with tranexamic acid. It's cheap, it's affordable. So I think all these things are important. Additional anesthetic techniques are important. So we need the support of the anesthetists in our surgery. They do very well with the patient comfortable. You are sure that the anesthetic taking care of all the other parameters. The surgeon can concentrate on the surgery and do very well. So this is my presentation on how we can minimize the bleeding in cancer surgery. And I'm sure there's a lot more we can discuss during Q&A. Thank you very much.
Thank you very much, Dr. Simotue, for that very practical fact. It was so practical. It can be presented in itself. We will now introduce our next speaker, Cassandra Upchurch, who will be talking on bloodless care, complementing palliative care nursing. Her bio, and let me run through it before she comes on. Cassandra Upchurch, MSN RNLC LNC, became a registered nurse in 2007 after attending Westchester University. She started her first role in the University of Pennsylvania Hospital in the trauma surgical ICU. After being in this role for some time, she continued into additional nursing experiences, including critical care, acute care, home health, stroke hospice care, managed care, long-term care, SNF, leadership, stroke nursing administration, bloodless medicine, nursing education, patient blood management, legal nursing consulting, infection preventionist, transplant coordinator, and travel nursing. Cassandra completed her MSN in nursing administration from La Salle University in 2021. She is the owner of and lead instructor of First Aid and CPR Academy, LLC, Anita Clinical Consulting, LLC, and Quality Care Professional Training Center, LLC, CNA Training Program. She also functions as an adjunct professor at Widener University Nursing Program. Cassandra has published multiple articles in medical and nursing journals. She has presented at national and international conferences related to bloodless medicine, business, and patient care delivery. She's a writer, course developer for NET, CE, and subject matter expert writer for GW, and clinical director for Tender Care Hospice, LLC. Cassandra is a member of various professional societies, including the Bloodless Medicine and Surgery Society and the Society for the Advancement of Patient Blood Management. Cassandra won't be present in person because she is ill, she took ill, and we are going to listen to a recorded talk. So it's my pleasure to welcome Cassandra Upchurch and her talk, Bloodless Care, Complementing Palliative Care Nursing. Thank you.
Yes, from the, I think, multiple dimension. Cassandra Upchurch, you have our attention.
Hello, everyone. Thank you for having me today. Thank you for being on. Today is a very important, or the entire week is a very important conference. So I know I've benefited greatly from hearing all the great information from all the speakers, everything we've learned. So it's definitely beneficial to have this exchange of knowledge, but also to be able to educate the community and those that may not be working in the bloodless medicine environment regarding the importance of bloodless medicine as a discipline. So I'm going to talk about nursing and advanced directives in bloodless medicine. And this talk is really to complement everything we've been learning so far, that there's a lot of medical and surgical techniques, but there's a large component where, again, as always with healthcare, the patient is the focus and center of our care delivery. So we want to make sure that we always have a way to be able to empower them so that they can make an informed decision. And bloodless medicine definitely allows nursing to be a huge contributor and collaborate in building that framework that makes a bloodless medicine to help drive that autonomy and individualized care for our patients. So we'll talk about that somewhat and the role of the nurse in that respect. So we're going to talk about the impact of nursing, implementation of the process of bloodless medicine, and advanced directives. So just a snippet about nursing as far as it contributes to the healthcare field. Again, the focus on this is on the nursing discipline specifically as part of the interdisciplinary team. So we do know that nurses RNs specifically make up the largest healthcare profession. So in the United States alone, we have 4.8 million RNs. And that's just licensed nurses that are RNs. That's not including all the other disciplines that fall under the umbrella of nursing as well. So definitely a huge profession, which means that that kind of reach makes it very impactful. So there's a lot that can be done on behalf of our patients when we have that kind of outreach as a team. One of the other things we want to consider is that nurses have also been one of the top rated professions with the Gallup poll as far as top ethic ratings. And so we all know that when it comes to ethics and being noted by patients as one of the most trusted professions, it means just that it makes it a lot easier and a lot more, it makes it possible to build strong relationships with patients. One thing that we do know is that there's always a barrier in healthcare and a delay in decision making and misunderstanding when a relationship and trust is not established because the relationship is not strong. And so this definitely impacts the patient and their ability to make an informed decision. So again, and we're also going to talk about the diversity in nursing roles. Nursing typically, like most other disciplines, exists in pretty much every area of healthcare. So we'll look and see what those areas are as it relates to bloodless medicine and surgery. So nurses' role in healthcare as it relates to nursing in the United States. So we have some very specific roles that are in the acute area and some outpatient areas as well. So you'll find nurses in these roles at the bedside, nurse leadership, your advanced practice providers being your CRNAs, your CRNPs, your CNS, your quality assurance individuals. They have roles in the OR, your coordinators, and the bloodless medicine program, in addition to your managers and directors. That's a part of leadership, and your nurse educators. All these roles are very important because that means that this is extended reach that we do have. These are additional opportunities for impact that we do have. And so this education that develops from the core in bloodless medicine, we can use those channels to help reach patients, to help reach the community as well, but also to change practice too, because of course, everything starts with research, and that's how we put that into practice. And so we want to keep that in mind when we understand that the strategies, everything that we do from a medical, surgical, or clinical standpoint, absolutely has reach in other areas as well as it relates to nursing. So we'll talk about that as well, as far as those pieces that build up the framework that really helps us to do what we do as healthcare providers, because we know that bloodless medicine is not just a discipline or strategies that will exist or is impactful just in the hospital encounter or during surgery, but also it starts before the patient is even in the hospital and it continues even after their discharge. So especially for our bloodless medicine patients, it definitely has a lifelong impact. And so although management will always be a part of the process, maintenance is very much part of the process. And so we'll look and see how that's done. So of course, we know all these important factors about bloodless medicine and surgery programs, that patients who are in these programs are refusing red blood cells, white blood cells, platelets, and plasma, that it allows individual decision-making, that there's alternative strategies or, enhanced strategies really for clinical management for patients, because as we've learned, especially on these conferences, that patients who are not transfused, they actually do better clinically. So again, it's an optimal healthcare outcome, but also that these programs are developed to facilitate that process, to kind of build that connection between understanding and practice. And so one of the things we want to consider is, we may know all these things about the importance of the program. We may know all these things about the impact of anemia and blood loss, but how much does our patient know? Regardless of how much we understand, how much do they understand, and how much have they been informed about their options? So again, benefits of bloodless medicine and surgery, but how are we communicating this to our patients? So again, are we giving them the information and developing tools and strategies and education and resources for them to choose the better option? We know it's a better option. We know it's a safer option, but in what ways that communicated to them? And again, what resources do we provide to get them to that point where they know how to make this decision, that they don't want blood, that they understand the benefits of a bloodless medicine program as well. We do know that patient blood management is definitely strategies that extends to every patient, because again, we should implement these very beneficial strategies to everyone. And bloodless medicine is more of a specialty for patients who under no circumstances will accept blood products or blood transfusions. But again, how much do they understand about the actual programs, besides the fact that a majority of patients who enroll in the bloodless medicine program, a huge driver for some patients is religion. And then you have a smaller percentage that will know a little bit more on the clinical side, and they refuse because they know the implications as far as outcome. But again, it has a huge, a larger effect for the overall population. So again, we need to make sure that that's understood across the board. So as nurses, a big part of the framework that we contribute to building is that the nurse is a big part of the primary assessment. So in a lot of cases, when a patient starts to become hemodynamically unstable, or a patient, again, is not fully aware of what options they have, or their labs or maybe their past medical history has a huge impact on how a procedure may go, and considering the best approach for this patient, that pre-assessment, in most cases, the nurse is a big part of the front lines, a big part of being a gatekeeper. And so when that patient starts to really deviate from what we consider normal or optimal, your nurse is going to be a big part, especially your bedside nurse.
I think she needs to go out.
Can you see my screen?
Yes.
Okay. Is really a big part of identifying these changes sooner than later, because we all know that early identification leads to early intervention. And so how do we, again, keep close eyes on monitoring this patient and picking up on even the subtle changes, even a change in their vital signs, a small change in their labs when there's a change in the pattern, or even a change in the patient's neurological status, which are early indicators of a patient decompensating. So with that being said, that's assessed early on, that's communicated across the healthcare team in order to allow all disciplines to really intervene sooner than later. But even prior to the hospital admission, the evaluation that goes into place, again, educating the patient so they're aware of what their options are, how to manage how to prevent anemia, how to manage anemia, and also those strategies they need to implement even when they're home. So again, we want to keep in mind that the nursing role, even in bloodless medicine, even in the hospital, has a huge is hugely impacted by the nurse being involved in the primary assessment and also early intervention as well. So again, we know the impact of anemia in hospitalized patients. We know the negative outcomes. We know that we want to avoid a blood transfusion. But again, as I always say, is how much does the patient know? How aware are they? We know in the community, we hear patients all the time discuss, hey, I think I may be anemic. and they don't think it's a huge deal. You know, you hear them say things surfacely like, hey, I'm eating ice chips today, I'm always cold, I think I may be anemic, and they don't think that it's a huge deal. But we as clinicians know that it is. So again, that driver, that impact in making sure the community is educated as far as what anemia is, how it affects them as a patient should they ever become a patient, but also how it contributes to them even becoming a patient in some cases. So even in everyday life, what are some measures that patients can take to, again, stay in the loop and engage with their providers in advance to have those necessary labs and preventive care done to avoid being in anemia and being monitored on a regular basis. But also, what are some strategies they can implement, even at home on a daily basis, vitamins, certain routines that they can do at home to even prevent anemia or even identify it early. So anemia evaluation and planning, again, hugely driven by healthcare providers, but again, your nurses being at the front line. So in many cases, even when it comes to your anemia clinics or patients that are coming in outpatient offices for PCP visits, and your patients that are in the hospital for pre-admission testing before surgery. These are labs that, again, your nurses are going to draw, your nurses are going to send those labs off. They're typically going to see them first. And when they see anything that's abnormal, they're going to report that to one of the advanced practice providers for an intervention. And as brought out in some of the previous presentations earlier this week, we know these strategies and we don't want to just do enough to get them through it. But again, we want to be meticulous in how we do what we do. So again, you know, the nurse, you know, drawing those labs, you know, how much are we drawing? How are we sticking the patient to get that blood? We want to keep that in mind. You know, again, when we talk about in nursing, you know, when I became a nurse in 2007, it was a whole thing where if a patient had a central line, we would draw weights first, and then we would draw blood. You know, so we really want to consider what techniques are being used when even these strategies such as phlebotomy are being done, when invasive techniques are being done for these patients as well. But again, the nurse is a huge part in those strategies that really could help optimize a patient's outcome by evaluating early, assessing early, but also performing any invasive techniques and preventive techniques to enhance the patient's outcome. So again, we also about continuity of care, because again, healthcare or overall health is a cycle. So again, there are all these components to it. So we always have the surgical and medical components that are crucial, right, for a patient, especially when they're already in that phase of crisis. But then there's all these pieces that have to happen beforehand, because we want to make sure that our patients, again, that they're informed, that they have the education that they need to make an informed decision. So are they aware of their options? Are they aware of the risk? Are they aware of the benefits? And so it really should be a care team discussion. And in many cases, and healthcare providers, we're definitely doing better with this, but there's this huge gap in literacy, understanding healthcare education. And so what we're learning is that even where we're simplifying conversation and not using heavy medical jargon, and really trying to use certain analogies and education to bridge that gap and knowledge with the family members and patients. We also want to do a good job evaluating how much they understand. And when we get an understanding of where they are, we want to meet them where they are. So again, really determining from an individualized standpoint how much they understand, what we need to do to mitigate that gap to meet that person where they are. And again, that differs from person to person. And we'll talk about some additional tools that some programs use to, again, make sure the patient has the information that they need to make this decision. Some of the things that I'll go into place to make sure that we are able to communicate those decisions are the consent forms that we do with patients, which also helps us to produce digital and physical identifiers to identify that patient as refusing blood products or blood transfusions. But again, all of this happens once the patient is educated enough to be aware of their options, but also to execute things like an advance directive that we'll talk about shortly. So again, it should always be a collaborative effort across the healthcare teams, where the bloodless medicine team and all disciplines really becomes a part of their care. So again, nursing being a crucial or core part of that medical team to ensure that that is there. So we do know as providers that trust is a factor, that a lot of patients won't even listen to certain won't even have certain conversations or make certain decisions because the trust factor is an issue, but we do know that there are disciplines that patients may view as dependable and trustworthy as well. We want to make sure that that's a huge part of the implementation of plan of care piece. And so having that trust factor and that relationship and that rapport really does help to, again, meet a patient where they are, kind of help them understand the benefits, but also help to execute those tools that will help the patient make decisions that are best for them and healthier for them, but also to communicate to us exactly what they do want so that there's no discrepancy or confusion about their decisions for their health care. So one of the things that, just go back some. One of the things that I want to highlight is that not too many individuals that are not healthcare providers give a lot of thought to, if I can no longer speak for myself, who speaks for me, who makes these medical decisions for me. And in some cases, people may have in their head a decision maker as far as who that person should be. But the reality is, if it's not executed in a legal document, there are certain state laws that dictates who does get to make that decision. And so for the state of Pennsylvania, this is the hierarchy of the healthcare decision maker in the case that a person does not execute legal documents like an advance directive. So in the case that there are no forms, it defaults to the person's spouse. If that's not an option, then their adult children, and then the parents, adult brothers and sisters, grandchildren, and so forth. So that's something to keep in mind, because we want patients to know that if you don't make a decision about your health care, the state will, so we definitely want to empower them by making them aware that it's very important that they have an advance directive, especially for our bloodless medicine patients, because sometimes the reasoning behind opting not to take blood is an ethical decision for a lot of our patients, but that doesn't mean that their family members are those ones that may fall in this hierarchy as a decision maker should they not execute an advance directive. Doesn't mean that they will respect that decision or even have the same belief system or would agree, especially if the person's life was at risk and they didn't understand all that entailed. So I'm just going to go this way first. Okay, so for our Jehovah's Witness patients, typically, of course, they have the no blood card, this advance directive, which is very helpful in deciding what that person wants done in their behalf should they no longer be able to speak for themselves, as well as identifying a healthcare agent and an alternative healthcare agent, and that's very helpful. But when we get to our programs, and every program is very different in what kind of form they execute, but you want to have a hospital, or we have a hospital specific form that speaks to, who they want to identify as a healthcare agent, what they are refusing, specifically for our bloodless patients, those red blood cells, platelets, plasma, white blood cells, but also a checklist that accompanies it to identify which derivatives they may be open to accepting. But also that form ensures that there's an education piece that they understand what they're signing. So this form allows us to get information to determine what they do and don't want, but also allows the patient to see what their options are and make an informed decision, because there's an education piece in there as well. So they're not just signing a contract that really speaks above what they may understand if they're not a clinician. And this advance directive should be accompanied, as we all know, by a detailed conversation and education by our bloodless medicine and surgery team while the patient is completing this. So some of the tools that can be developed as a result, one second. Some of the tools that can be developed as a result of having that conversation to provide an education are really quick fact sheets. Patients are really good about having certain conversations, but we do know, like with anyone, especially if it's not their specialty, people will walk away from that conversation, and as time progresses, either that's archived information and they don't remember the details or don't remember the rationale behind what was just discussed. And they definitely may walk away with their own interpretation of the conversation, especially if they're talking to additional individuals, because that's what we do sometimes. We go to an appointment and then we go home and we talk to someone close to us, maybe a spouse, maybe another family member, and we reiterate exactly what happened in that conversation, but it doesn't sound the same. It's not the same information because it may not fully be understood. And so again, it's really important because we always want to make sure that patients are able to walk away, whether they're enrolled in a program or not, or just have access to an educational tool that provides detail as far as what their options are in a very concise but detailed way, so they can get to the fact of the matter. But also, most importantly, for our programs, how to utilize the program. We know a Bloodless program exists. What are the steps to be enrolled? What are the steps to get more information? What are the steps to be followed as a patient to make sure that I have an advocate to ensure that my wishes are absolutely carried out and that we can have this ongoing communication. And so that framework with other disciplines and nursing being involved helps to produce educational tools and resources that really help contribute to the framework of a bloodless medicine program, but a patient being informed enough to execute an advance directive and understanding that if they don't make a decision for themselves, a decision will be made for them if they do not, even from a legal standpoint. Also, again, as everybody who has a bloodless program knows, this also helps to develop other identifiers, these physical identifiers that we talk about, that helps to enforce to the healthcare team that this is a patient that's refusing blood products. So in summary, and this was one that most of them look the same. This is one that we did for Lincoln All Hospital when we were building that program. And then we have the patient arm bracelet that accompanies the regular patient bracelet for patients that enter the hospital, and stickers for their chart as well, like most bloodless medicine programs have as well. And so in summary, we just want to highlight that all disciplines are necessary to have a successful bloodless program. And we just wanted to take the time today to really emphasize the importance of the role of the nurse in the bloodless program as a driver and developing these programs and really enforcing the strategies, but most importantly, that communication and relationship with the community and patients so that they can make an informed decision and feel empowered about their decision. The Bloodless Medicine program is important in facilitating all these pieces because we know education, again, helps facilitate decision-making, research, workflow, and processes. So it really impacts how we do what we do and why we do it, and also to achieve optimal outcomes for our patients and continuity of care as well. Just a few references, and that is it. Thank you so much.
Thank you so much for that wonderful presentation, Cassandra. We really enjoyed it. And just the importance of how that we are the largest healthcare profession, and very important to have a bond with our patients and that they trust us as we take them through and help them manage their care and basically empower them and educate them. So we really appreciated that. Thank you so much. Also, we've got some new visitors since we've come on and started. So I want to welcome everybody again to our BMSW week on Friday. At this point, we're probably going to open up and start the discussion for Q&A. We want to remind everyone that we're going to introduce all our panelists. And we have Erin Saddam, Ilya Pleshny, Iniabasi Alori, Sarah Ivara, and Sherry Azawa today to be our panelists, but also we're welcoming anyone else that does wish to or desire to have some input. But we are asking that all the panelists indicate their desire by raising their hand electronically. And also, you may also type your questions and we may respond to you that way as well into the chat or the Q&A. I don't see that anyone has any questions in the Q&A at this time.
There was a question that Dr. Blomberg answered. Maybe he might want to answer it openly for everyone. He typed an answer. I don't know whether he wants to share the answer with all.
Okay. Did anyone have any questions or something they wanted to share for Dr. Samato or Cassandra?
So the question that Dr. Blomberg answered by typing is, does the early intraoperative use of tranexamic acid increase the risk of post-op bleeding? And his answer was, I don't believe there is any evidence that this occurs. But if Dr. Simutoe wants to add to that, he can add to it.
Thank you, Nathaniel. I haven't found any effect of transaxle causing more bleeding. In effect, I think I find it to be causing less bleeding. All the cesarean sections that I do, I always give a bolus when I'm doing the incision. I give another bolus when I remove the placenta, and they've done very well.
Yeah, that has been our experience here too.
We have some comments and questions in the Q&A chat here. One of them is from an anonymous attendee. Thank you so much for the informative presentation. I'm wondering if it is possible to have the copy of the advanced directive form for a closer look. Thank you. Sounds like something for Cassandra.
Yeah, but Sandy, you are very qualified to answer that.
Oh, I would say yes.
It's possible to have it, I think, from the HLCs, right?
Well, as far as the advanced directive form, from the HLC, you would definitely go through your HLC, your local HLC, and work with them, as well as the elders of your congregation, if you are one of Jehovah's Witnesses. As far as with the hospital, if there is something that the hospital provides for those that are truly PBM, patient blood management, that is something you could take up with your patient blood management team as well for your local area. As I kind of thought maybe that was something that they were asking about first Cassandra with the one slide she was showing, which was very informative. So the next one is from Veronica Falcone. BMSP telehealth has opened up for us. Has anyone experienced in the role evolution and recommendations for success? So we can think about that one for a moment and come back to it. We have another anonymous attendee who is saying, is there a basic overview website for today's material? Please and thank you. Yes, we have the BMSS website. We also will be posting this on YouTube afterwards to be reviewed. And sometimes the answers are right there in our presentations, but the slides maybe weren't up long enough to really take some of the information in. So it's always nice to be able to have that recording to go back to. I hope I answered that well.
Yes, thank you, Sandy. So there's the BMSS YouTube channel where the videos are uploaded. In the next few weeks, I think all the videos will have been.
Okay.
So Dr. Jadwin, can you give an insight into this BMSP telehealth?
No, I'm sorry. It's not too much I know about, but do you have something more specific to ask? Or I'm not that familiar with it.
Okay. And yeah, okay. We're gonna
I
have
can
some.
tell you a little bit about the work we're doing, but other than that, I can't comment about that. But
Anyway, I think we're going to hear more about. We're going to hear more about this high-tech stuff in November during the annual meeting. The annual meeting, the theme is medical informatics, and I think all these matters of telehealth and other things will come in there. So Veronica, please stay with us and join us in November for the annual meeting.
That said, Veronica, I think that's a great inspiration for the industry health leaders to work on as far as from a PBM standpoint and bringing patient blood management telehealth to our professional angle would be wonderful, and to span that across to, you know, not just countries that are more developed, but also countries that could use that provision in areas that are not as developed would be wonderful. So yes.
Let me ask the question. I'll direct my question to Dr. Simotori. Thank you again. Yes, your presentation was minimizing blood loss during cancer service. But I was just wondering, is there a place for transfusion during cancer service? What do you say about that?
But you're asking, is there a place for what?
Autologous. Perhaps using flare or whichever method. Will it disseminate cancer cells? Is there any fear? Is there any contraindication? Yeah, Ken, I think your sound is very poor. But I think I could read your lips. Were you asking about blood salvage? Yes, in cancer. Okay, so there's going to be a full talk on that tomorrow. Dr. John Waters was not able to give his talk yesterday because he was in the OR. But he said he's going to be here live tomorrow to talk on blood salvage in oncology, the facts and the myth. Mm-hmm. Do you have any more questions? I see like
We
eight questions.
Yeah, we have a few more in here. Let's see. And thank you, Veronica, for all your input as well. We appreciate that. We have one here from David Aji. It says, did you say there is a lawyer on the panel? If yes, what is the legal position of the law if the medical regulatory body disregards a patient's properly signed advance directive and finds the practitioner guilty of malpractice for agreeing to the patient's wishes for bloodless management? This is in a situation where the outcome surgery unfortunately is negative and mortality occurs and litigation is instituted by patients' relatives.
So we did have a lawyer with us, but I think not here at the moment. But we had a full session on ethics and law in November 2023. And the videos are online. They're on the BMS's YouTube channel. So you could go view that video on the legal aspects of bloodless care. On my own part, as a surgeon, I know that the ethics of the practice insists that patient autonomy must be respected. So that's the number one principle of medical ethics, patient autonomy. Therefore, the patient's wishes must be adhered to, whether they are conscious or unconscious, especially when they have advanced directives. I don't know if Ken or any, okay, Dr. Simutue, if you want to add to that.
Yeah, I think you're right. The patient's directive is very important. We do face challenges sometimes. Recently I was required to give advice where the patient refused for a child to be given blood, and the parents refused, but the hospital used their lawyer, their secretary, to overrule that, and they went ahead and gave the child blood. So they've been taken to court to see how things work out. But always to respect the patient's the directive is always better.
Yes, we have in the literature where hospitals have lost large sums of money and also doctors. And I think some have been suspended at times for failing to respect the patient's autonomy. So it's a very strong principle in medical practice.
This is also where Cassandra Upchurch's presentation really was appreciated and informative, because it is so true. The more you educate your patients so that they understand what their rights are, what their responsibility in their surgery is, so that they can make the best informed decisions and go in understanding and knowing just how much power they have in their own healthcare. We have another one here, another question. Says from anonymous attendee as well. Are there opportunities to be trained as a patient advocate with your organization, BMSS, or such supportive groups? Thank you.
Yeah, certainly we keep having these events twice a year. There's the Bloodless Medicine and Surgery Week, then the annual meeting. And we do feature various aspects of bloodless care, I think including advocacy. But maybe we can, again, that's an idea. Maybe we can have a full session on that as well in the future meeting. Sandy, Chris, Ken, you're all members. So if you have something to say on that, please go ahead. Of course, advocacy is key, and this is part of advocacy. And then the website is there, the YouTube videos. So I think the first thing is to become a member. If you are on the page, you'll get the test information that you can disseminate. Okay, from me, for example, all of my class page of more than 200 former classmates, they get updated information as it comes. So I think the first step for the anonymous attendee would be to request to become a member. Then you will really help with the advocacy.
Yeah, certainly. This is the best education you can receive for patient blood management, and anything having to do as far as advocacy as these societies, patient BMSS, as we have here. You're learning the state of the art, up-to-date information. And it's definitely a learning process, but there's so much material out there from different societies now, BMSS and SABM, of course, Society for Advanced Blood Management, and now we have MyPBM, and there's more now, and there's really a lot out there to glean from. And of course, you'll find that if you have questions, to reach out, anyone that is a leader in the industry of PBM, or working in a patient blood management department in their hospitals, you can locally find often that the help is there. Everyone's willing to, coach and support each other through this process, especially if you have someone who is going to be needing some assistance with that.
Chris, you wanted to add to that?
I think you're right. I think Kenneth and Sandra have actually elaborated quite well. And I think going to the website, I'm sure there's always enough material there. So I think all those who really want more, they can go to the website and also check on YouTube.
Yes, we needed to hear from Chris because he's the president-elect of the Bloodless Medicine and Surgery Society. So whatever I say now may be null and void by November when he takes over. So at this time, we're not, you could say we still do advocacy. We do a bit of advocacy, but the thing is that we believe that bloodless care. Sorry, somebody's microphone is. Oh, it's Dave's on. Okay. So we believe that bloodless care should be the default. It should be the number one thing. It should be the standard of care. I tried to share my thoughts on that, and it's not only myself, but there are many other clinicians who look at it that way as well. So it shouldn't, the advocacy bit, it probably should be for others, not medical people. Because like saying that we should be advocating for patients with malignancies to have multidisciplinary care. I think it should be an established practice. They should all have multidisciplinary care. Well, and advocacy can still be part of trying to get colleagues to accept bloodless care and not to say that their hands are tied behind their back.
Mm-hmm. Thank you for that, Nathaniel. Also, we have a few more here in the Q&A now. One is from an anonymous attendee, says, I read that the patient blood management PBM is a nationwide initiative. Do you aware of any such programs in Ethiopia? If so, how can we reach them?
Chris, is Ethiopia anywhere near you there?
No, I think we can able to find out. I don't know anyone at present from Ethiopia.
Yeah, so patient blood management is now a World Health Organization, should I say initiative. The World Health Organization is asking all affiliates to take up patient blood management, to teach it, to practice it, and so on. And frankly, as we heard from the definition of patient blood management and the history of patient blood management, we know that true patient blood management originated from Bloodless Medicine and cannot really be effective without bloodless care. So, I mean, once you remove bloodless medicine and surgery from patient blood management, there's actually nothing left, because all the good things, all the beneficial effects we see in patient blood management have to do with those techniques of bloodless medicine and surgery. That is why recently, I think that there was a team from the UK that published a paper renowned individuals, they published a paper and said that there's no benefit in patient blood management. Very shockingly, the whole patient blood management world was shocked. But I wasn't too shocked because what they were talking about is patient blood management without bloodless care. Like reduce the amount of blood transfused and all that. But there's a paper last year from based on Society of Thoracic Surgeons database that shows that even when you transfuse one unit of blood, there's still a lot of problems. And so they are advocating for zero transfusion. So there's an initiative from the World Health Organization. I believe that Ethiopia is a member of the World Health Organization. I think the head of the World Health Organization is from there. So I'm sure he will make sure that Ethiopia is not left.
Thank you, Dr. Nathaniel. We have a few more here now. Here's another one from an anonymous attendee. Would bloodless nurse coordinators be eligible to be recognized by the American Nurses Credentialing Center and have the opportunity to advance their nursing career and prove their ability to provide the best patient care? So does anybody want to contribute to that one?
Which in the best to take that question? Does anybody practice the US?
Do we have any?
That.
Yeah, do we have anyone from the States?
Anyone from the States that for what?
That maybe has some updated information or the latest on credentialing for bloodless PBM. I know we are definitely trying to advance that to be recognized, but maybe someone can give us some up-to-date.
Unfortunately, Sherry is not here yet. She would have been in the talk to us on that. I think she said she'll be here in 5 minutes or so.
Okay, we can come back to that. Here's another one, anonymous attendee as well. Not a question as such, but more an assurance that as an HLC member, part of the role is to help the patient make informed decisions about the procedure/treatment and also the legal issues using the appropriate policies and documentation, etc. What if a patient had dementia and no advance directive to hand, a planned pregnancy also, and if warranted, any issues involving a newborn child, etc. So absolutely, that's where empowering the patient or the family of the patient as well, and having an advance directive is so important. We have a few more coming in.
I do have a comment. In the United States, I really don't find that much problem with blood use in the OR. Where I do see the problem is that the surgeon has worked, and particularly cardiovascular surgeons have told me that they've worked hard to not give blood in the OR, but then they get onto the unit and they get transfused by the hospitalist. And I don't know how much of a problem other people have seen this, but I think it is a problem. Cardiovascular surgeons particularly have said, I bent over backwards to do a bloodless procedure, and then when I came to the unit the next day, they'd been transfused with 1 or 2 units.
Hmm.
Yes, that is a shame. after all that hard work. Anyone have a comment on that? Thank you, Dr. Jadwin. We can come back to that as well if anyone wants to share any more on that as in addition to that. It says we have another couple here. Another one is, oh, here's one from Peter. I hope I'm pronouncing this right. Dewaley says, how known is this organization? Dr. Samituo or Dr. Osoro, Professor Osoro, might want to elaborate on that.
Well, Peter is here with us, so it's probably well known. I don't know where Peter is joining from. But we could use some help. We could use some help to advertise us a bit more.
Always that, for sure.
Chris, you want to add to that?
I think we still need more advertisement. Yeah, it's like the question that came for Ethiopia. So we need to see how we can make more people to access our site.
Sure.
This is my first exposure to the society, and I was just wondering, has it always been a virtual meeting, or have there been physical meetings as well?
Oh no, once upon a time it was physical meeting. In fact, the last physical meeting we had was before the pandemic, 2019. And we had guests from the US. Sherry was there, Aria, and Dr. Shanda was there. It was held in Calabar, Nigeria. So when the pandemic came in, we migrated online. And I guess we've sort of gotten to love the online because it allows everybody opportunity to join from wherever they are, from the comfort of their offices or their homes. But now that Chris is going to be taking over as president, maybe he will arrange a meeting in Zambia and a safari as well. So we all get to kill two birds with one stone. So from 2020 till date, we have been having online meetings only. Though we do have, we do organize events, local events within hospitals and other venues, but not something that everybody can attend. For instance, last week we had an event in our local cancer center here. So we gave a talk to them on bloodless care in oncology. And they organized a town hall meeting such that all members of staff, clinical, non-clinical, could be there for the lecture. And then some medical students and others also came. But outside that, we haven't been having any big meetings.
I do think it's important for people to share their data. One of the tenets of the special credentialing that I think nurses are looking for is to participate in research. And, you know, it's one thing to sort of talk about general aspects of patient management, but I think it's another to share how these patients are being managed and the type of success that people have so that we can quantitate that and, you know, build on that. So I just want to make that comment.
Yes, I agree with you, Dr. Jadwin. And I have to say, Dr. Jadwin has been shining the light for us in this regard when it comes to data, because many of us appreciate data, but we shy away from contributing to it. So I think he's trying to jumpstart all of us to make sure that we use we provide data and analyze effectively. He owns various facilities that can help with that. I think Professor Ilori's hand was up. She wanted to comment.
Yes, I wanted to comment on the issue of advocacy, or that whether the society is well known. I remember when we started here in Nigeria, it was not well known, but what we did was that in most surgical conferences within the country, we had presentation. So for the East Africa, if you do have your regional surgical conferences, that is where people will become aware of the society. You can do presentation on the bloodless medicine and surgery. Dr. Soro really did a lot, because almost all West African College of Surgeons conference, there was always a session on bloodless medicine and surgery. In the Nigerian Society of Anesthetists and conferences, there was also a session on bloodless medicine. So that is the way you can create awareness in the eastern part. As far as West Africa and Nigeria is concerned, because of all this presentation, a lot of people are aware of bloodless medicine and surgery. And whenever, because a lot of people are aware, when we advertise, it's being advertised in different societal platforms. And that is why people from different walks of life do join the conferences or the meetings that we have. That's what I have to say.
Thank you, Professor Ilori. Professor Ilori is a founding member of the Bloodless group that we have here. And also she is a life member of the Bloodless Medicine and Surgery Society. She's been joining us, helping to make presentations all over West Africa, I should say. We actually have sometimes gone beyond West Africa. We've been in Zambia with Chris, been in South Africa, and where else? Kenya. Okay, Kenya was on something else. Anyway, so I think I should stop and hand over to the panelists, to the moderators.
Thank you, Dr. Soro. By the way, we really appreciate you being part of the question and answer as well with us. There are a few more here. We'll just kind of look at these real quick. Looks like someone, Efiwat Andemiwa, about 15 years ago, staff nurses were trained to carry out cesarean sections. Most were accomplished in bloodless, in a bloodless manner. Dr. Andemiwa Hospital, Lagos. And then further says, this information above is from Ethiopia due to doctor shortage. Does anybody want to comment on that, or is that kind of?
Okay, I think we will be typing the answers so that we don't eat into Sherry's time. Sherry's
Okay,
here.
that sounds good. Welcome, Sherry.
Oh, okay. We can seize that opportunity to ask her that question that we're keeping for her. I think it had to do with nursing credentialing.
Okay. I'm answering now, Nat, or later? Do you want me to?
You can answer now because it was part of the last session. Can you see the question?
Let me look quickly. I'm not seeing that question. Sorry, in the question list.
Yes, Sandy, please, could you read it for her?
Yes, absolutely. Well, there's a couple of them in that kind of in that subject there. The one we wanted to go to was, I think was that Veronica? I think, okay, this is probably the one right here. It says, would bloodless nurse coordinators be eligible to be recognized by the American Nurses Credentialing Center and have the opportunity to advance their nursing career and prove their ability to provide the best patient care?
Okay, so thank you for the question. So, you know, a subgroup of folks from SABM has been working on a submission to the American Nursing, I hope I get the name right, Association, you know, the governing professional society for licensed nurses in the United States. They do have some international tentacles and are certainly interested, as they've described. We're working at a pretty senior leadership level with them. I think there's 5 folks, and again, I apologize, I haven't joined earlier in the week. I don't know if others may have already mentioned this during this webinar series this week, but they have, we've been working with them for, I think it's going on 2 years. And of course, like any organization, they have a very structured process to develop a new specialty. In the United States, at least, there are these specialties in nursing that are tied, as our questioner asked, to the ANCC, the Nursing Credentialing Center, and in some combination of what that nurse does in everyday practice for his or her job or their job, as well as passing some type of exam, they get a credential of a certification in a specialty, regardless of their education. So it's not tied necessarily to the level of degree they have. And so there's a lot, I don't remember the exact number. There's 29 or 30, whatever that number is at the ANC, oncology, nephrology, as you'd expect, these different, subspecialties. So we have really checked all those boxes and done a tremendous, I'm an advisor, but I'm not part of that working group. Becky Rock, maybe she talked about it already on this panel, because I think she joined earlier in the week, but they have submitted that to the ANA. That is under digestion. They are also going to publish that work as appropriate, or try to submit for publication to a journal. But if that is successful, then patient blood management will be recognized as a an emerging nursing specialty. So a long-winded answer, but the idea is that's what we're going for. Will we get there right now? I can't say for sure. I think it definitely meets all the criteria that, at least from the ANA perspective, a nursing specialty needs to meet. And we had to give them lots of background. Where did this all start? The bloodless piece, the PBM piece, all of it. But if they do, right, and I think it's just the end. How many nurses would then qualify to go through that process to become certified in patient blood management? But that's a long-winded answer, but we hope so. That's our goal. We've done every step we can do in the United States at this juncture to have that recognized by the governing agencies for nursing certification.
Thank you so much for that, Sherry. We have so many comments still here and questions, but we do have to move on and keep rolling, unfortunately. We will try to answer some of those in the Q&A as well, though, at this time, just so we can segue. Actually, Sherry, your comment actually was a really good one, just to segue into your next part. And so I want to take this moment as we close Q&A at this time, as far as live conversation, and introduce Sherry Ozawa Moriello. She's an RN MSN, sorry about that, Sherry. Also Director of Clinical Operations and Delivery, Comprehensive PBM, Patient Blood Management, Acumen Inc. USA, which is really highlighting patient blood management and making all of us proud, really. And past president of SABM, which is, of course, Society for Advanced Blood Management, to lead in the panel discussion with the theme, Avoiding Blood Transfusion, Saving Lives. So go ahead, Sherry, with your presentation. Thank you.
Thank you, Sandy, for that kind introduction, official introduction. So I move my screen here. So I know that we have with us Miss Effiom. I think I see her on my screen. Idorinin. I'm probably not pronouncing it adequately. And I think that Dr. Usoro and Dr. Ilori, you're both involved in the care of our patient, if I understood that correctly.
Yes.
Okay.
Right.
So I see her, right? Is that, I'm going to call her Miss Effiom on the screen.
Okay, you want Mrs.
Oh, there she is. Okay.
1 second.
Good afternoon. Good afternoon, doctor.
Okay.
Sherry, is she the one you wanted during the film?
Good afternoon, doctor.
Hi,
Yes, I
hi,
can
Ms.
hear you.
Effiong. Can you hear us?
Good afternoon, doctor.
Yeah, can you hear us, Mrs. Effiong? Can you hear us?
Faintly.
Oh, faintly.
Faintly.
Okay, I can hear you very well. Sherry, can you hear her?
I can hear her. She can hear us. If so, we can get started.
Okay. So she says she
Good
can hear
afternoon,
us
doctor.
faintly. Yes, good afternoon. So Sherry is
Yeah,
leading
okay.
Sherry's leading the discussion, and she's about to start. So if you can at least hear what she's saying, then
Sure.
actually, Sherry, maybe she was expecting you to start with Sarah. Let me see where Sarah is. Sarah, is your video on?
Yes, doctor.
Okay.
Good
okay.
afternoon, doctor.
Okay, all right. Good afternoon. Sherry, you can go on with her, please.
Okay. So, so could you tell us, Mrs. Effiong, the surgery you had and when it was, and how did you come to need that particular procedure, that surgery?
Good afternoon, doctor. I was diagnosed 2000 of locally invasive carcinoma, 2022. And I was appointed to go for surgery. I went for surgery, and my surgeon introduced me to bloodless surgery, gave me some advantages. And when I viewed the advantage over the other option, I opted for bloodless surgery. And I went through, it was left breast mastectomy. I went through the section, and I had a very successful section, and the healing was rapid. And by 1st June this year, to be make up 2 years, I've been very strong and healthy.
Wonderful. Well, you look great, so I'm happy that things went well.
Yes.
So, right, we are very familiar on this panel with bloodless surgery, with the value. How did you feel like others around you, friends, family, did they feel like you were making the right decision opting for bloodless surgery? Were they familiar with the concept? And how do you feel about that?
All right, since it's not something that is very common, I was advised to opt out of it, but I had confidence in the surgeon that told me, and I went in for it. I didn't mind so long as my husband was in agreement with me. So I went for it. And I thank God it was successful and everything went on. My healing was very rapid. My blood built up. Before I went for the surgery, I was advised by my surgeon to build my blood up, and I had a HB of about 13.8 before surgery. Though I have history of excessive bleeding, which I informed him, and he managed the surgical section where it dropped around 7 after the surgery, and I was able to build up with some drugs, and I eat vegetable a lot, so the thing goes up to normal rate. Before I left the hospital, my blood count was okay, and I built up the remaining one. Even as at the last checkup I went, my HB still went back to 13 point something, about 13.8.
That's wonderful. No, that's great. Maybe at this juncture, I'll ask maybe Dr. Usor, you can comment, or any of other panelists. This is always a challenge, at least in the United States, for those of us who are here from the States, in that preoperative period to optimize patients. Again, we have sort of the complications of complicated insurance plans and other things, along with that patient education. How do you find that patient engagement piece to go in your part of the world? And, you know, do you have advice? Because our friend, Mrs. Effiam did a great job helping herself optimize for surgery. And I'm sure you do that with all your patients, try to get them to do that. What's your advice to us in other parts of the world to help our patients engage just like she did to help themselves?
Okay, thank you. So, yeah, we start quite early. As I mentioned in my presentation yesterday, we are not shy about using oral hematidics, even though the medical literature does warn us that the oral route might not be the best in malignancies and the inflammatory conditions. But even if a little is being absorbed, we do use it at least once we see a patient walks into the clinic for the very first time, we have HemoQ that we can use and know the hemoglobin. And we start already on oral hematidics while the patient is being walked up. Mrs. Effiam is a special case because she has this plant that grows in her farm, and which she says is very effective. And we saw it. She just makes it into a drink and drinks it. And lo and behold, the hemoglobin shoots up. So maybe I have plans for my retirement that I'll go into that plant, then start selling that plant. If she's
you're going to be business partners, or you're going to retire here, rich people from the plant.
So my advice to all of us would be, if you have point of care testing, go ahead and use it. But if you do not, you can order a full blood count at the initial visit. And even while the patient is going for that full blood count, they should go along with a prescription, at least for prophylactic hematidics. Iron has to be in it, vitamin C. Folic acid we don't use for malignancies because we use antifolate as part of our chemo. So we don't want to use folic acid, but if necessary, we can go for folinic. But talking about just that initial visit, iron, vitamin C, multivitamin, vitamin B complex, we can start at prophylactic level. If necessary, we can increase the dose of the iron. But at a certain level, following our own protocol, we can go for IV iron.
And do you, anyone on the panel, do you provide like any written patient-facing materials about, you know, optimizing yourself for surgery? Do you find that helpful?
Normally, for us, like I'm an anesthetist, we don't really have the chance of seeing a patient, but before surgery, but of recent, we have started our pre-anesthetic clinic. So if a patient comes there and has a low hemoglobin level, we always prefer to optimize them rather than give the blood transfusion. But the challenge we have for cancer patients is that most of the time the patient presents very late in the advanced stages of cancer here. And by the time they come, they already develop anemia. So most of the time is the intravenous iron. We have to build them up with intravenous iron before the surgery. For those that don't have advanced cancer, which are being diagnosed, which is very rare, unless during the screening period, they can go on oral, but most of the time it's the intravenous iron that is preferable.
Okay. Thank you. So, Mrs. Effiam, to wrap it up, any regrets about your decision to go the bloodless surgery route?
I'm proud about that decision because it's helped me save my finance in other way, and also my hospital stay was greatly reduced. Excellent. I'm happy with that decision.
Wonderful. Anything else you'd like to share with our audience? We're happy to see you well and healthy and happy and looking wonderful.
Thank you, ma'am. I'd like the audience to not to shy away from any option the medical personnel feel is good for them. Like when my surgeon informed me about bloodless surgery, he gave me the advantages. And I reviewed it and saw it was good for me, and I went in for it. And today, I can proudly say I'm proud of that decision I take.
Wonderful.
Thank you very much.
Thank you. Thank you for being with us. And we're, again, so happy that you're well and able to tell
I'm
us.
also grateful for the opportunity to join this forum.
Wonderful.
At least I've learned a lot in addition to what my surgeon advised me. I've learned a lot. I can also advise others that have similar situation.
Yeah. Well,
thank you very much.
That's the most important, hearing the real experience. Thank you. Thank you for joining us, and we're so glad.
Thank you.
And thank you. And so we also have with us Sarah Irada. Nice to see you, looking lovely in purple. So Sarah, we'll ask sort of a similar question as we asked to our previous patient. Tell us a little about your surgery, the timing, and how you got to where you were to make that decision.
Yeah, thank you for having me in this platform. The surgery I went for was myomectomy, and that was done on the 16th of January 2024. And why I went for it was because of my Christian faith, which states that if I abstain from blood, I will prosper and have good health.
So this was pretty recent, right? We're only a few months out. You're looking wonderful. How do you think, from your perspective, your recovery, this is only your perspective because you're the patient, but it's a relatively common surgery, myomectomy, or a lot of these gynecological surgeries. From your perspective, how do you think your recovery was compared to maybe what people might consider a traditional approach, which may have been a little different in terms of the view on blood?
Yeah. It was actually my choice to choose bloodless surgery. Yes, because as I said, I wasn't forced into it. I chose bloodless surgery out of my own choice. And the recovery was perfect.
Good, good, good. And so you and certainly our physicians, Dr. Usor, Dr. Ilori, others can weigh in. What kind of steps? I know we heard some of that in terms of preoperative preparation, excuse me. So what other type of intraoperative techniques would be used for a patient like Sarah in her case, or others?
Yeah, so this is gynae surgery. So I'm not a gynecologist, so I have an idea of the bloodless steps that are taken. But I think first of all, Sarah has wanted to.
Sorry, can you come again with your question?
Okay, so Sarah, the question was to me, but maybe you want to tell us how you went about seeking for and obtaining bloodless care. Can you hear me, Sarah?
Yeah, at first I'm uncomfortable. Can you hear me?
We can hear you now. So how did you go about seeking for and obtaining the bloodless care?
Like I said, at first I was having this abdominal pain that was making me uncomfortable. So I went to the hospital to explain myself. And after some test was carried out, I was diagnosed I had uterine fibroid. Made it clear to the doctor that I would not wish to accept blood transfusion, of which the doctor accepted and carried out the surgery without blood transfusion.
Well, that's great.
Thank you. So Sherry was asking what steps would be taken. Sherry, are you talking about pre-op? Okay. So
yeah, I think we covered the pre-op, but maybe some of those intraoperative techniques.
Okay. So in here, because I work with the obstetricians and gynecologists as well, like in Sarah's case, they actually sent a consult to me and my unit so that we could join them. That's what they do whenever they're having a bloodless case. So we've said some bit about the pre-op, and then intra-op, they favor like for mammectomy. By the way, Sarah, yours is a benign condition, so don't be scared that you're coming on to a conference that has to do with malignancies, with cancers. Yours wasn't. So for Sarah's case, which the mammectomy, they used a spinal anesthesia, which is known to be associated with less blood loss. And prior to skin incision, they gave a bolus of IV tranexamic acid, 500 milligrams, and then put another 500 milligrams in the IV fluid, which was in 500 ml aliquots. That is, each bag was 500 mils of the IV fluid, and they added 500 milligrams of tranexamic acid. She was also given intramuscular vitamin K, which is also known to reduce hemorrhage. I cannot remember whether they used diathermy. We often use diathermy in my own section, but the gynecologists, I mean, once we give that tranexamic acid in that fashion, quite often they don't bother with diathermy. They just go on with their knives, and the field is usually reasonably dry. So the surgeon, that the gynecologist, was meticulous in the hemostasis all the way through the skin subcutes, and then got to the pelvis. The next thing they did was to apply a tourniquet. So that's what they do here. They apply a tourniquet. For tourniquet here, they use a Foley's catheter, and they simply encircle the cervix with it. I think they puncture the broad ligament one way and come out the other way, and then tie it tight. So that shuts off the uterine artery and uterine vessels. And so they can do whatever they want. There's going to be no bleeding. So the mammectomy was done. It was quite a large, I've forgotten the uterine size, maybe around 24 weeks or so. So they took out quite a lot. And there was virtually no bleeding. And then they will finish with that, and they start suturing, putting hemostatic sutures, even though there's no bleeding. And then when they're done, they will then release the tourniquet and check again to see if there's any residual bleeding. And usually there's not much. If there's anything, they might put a figure of 8 stitch. The surgeons know that kind of stitch. Occasionally, we have used topical hemostats, but that's unusual. So that is it, but we also prepare for eventualities. So all our patients would have a plasma expander, a colloid, available in case. Most times we never use them. It wasn't used for Sarah's case because usually there's hardly any hemorrhage. The obstetricians, the gynecologists, they've never lost any patient bloodless case, I mean, from hemorrhage or from any surgical complications of mammectomy. I don't know if I've covered it, or you can ask any other questions.
No, that I think that covered it. Thank you for those important surgical details, but it's important to know. But back to Sarah, we see the outcome. You already described that the outcome was successful. We can see you looking fantastic. So do you have any regrets for choosing bloodless surgery? And how would you describe to somebody who is thinking about it the benefits?
Actually, I have no regret for having bloodless surgery because I was discharged on the 4th day post-op, and there was no breakdown of wound, no complication, good PVC post-op was noted. So there's no regret going for it.
Wonderful. And what other thoughts might you want to share with this audience or others?
Yeah, I would like to tell the audience that bloodless surgery is the best. It's less financial burden, better outcome, no complications attached to it. And above all, I think one will have a clean conscience with God for obeying his laws.
Wonderful. Are there any other comments from our either of our I think we lost our other patient. Oh, she's still here. For either of our patients or our panelists. I think, you know, having our patients as part of this is such an important piece. And we know that even the data tells us, right, that when patients are engaged with their own care, the outcomes really are better for everyone. So I guess the challenge before us is how to keep our patients engaged when they're very worried about whatever medical condition or surgical condition is in front of them. How do we keep them engaged as partners in that, both their pre-op care, the concepts around bloodless surgery, and their recovery, and then spreading the word.
Yes, that's right. We do have to spread the word. We have to maintain the awareness. And I'm sorry, but I have to say this, Sherry, because I've noticed that there seems to be a tendency to go backwards now, to go back to what we already know is bad. You find people, scientific sessions where people will get up and still start their presentation with blood transfusion saves lives, with absolutely no shred of evidence, no scientific evidence. And we see people also coming to talk about giving whole blood, something that had been left behind. It has been clearly shown that whole blood is a catastrophe. And that is why in some countries they went to like leukodepletion. In UK, for instance, they go for leukodepleted blood, which still is associated with problems. So you can imagine people advocating for going backwards towards whole blood, wherever that initiative is coming from, whether it's from the blood industry or whatever. But if we're just sitting quietly without doing anything, without at least raising awareness, just bringing up the scientific evidence, which is abundant, that bloodless care is the superior thing to do. And that blood transfusion, even if it's 1 unit, because some talk about giving less. No, if it's 1 unit of blood, it is scientifically proven by some of the best researchers in the world that it's still associated with morbidity and mortality. So if we do not carry on this advocacy, so to speak, or this scientific kind of revolution, if we don't carry it on, future generations are going to wonder what was wrong with us. You know, why did they keep doing this for so long when they saw the evidence? The writing was on the wall. So I think I'm with you completely on that. We need to keep talking about it, both to our colleagues as well as to patients.
No, I agree. That's a challenging thing, and I think I'm sure Dr. Usoro, you and others have had the chance to be reviewers on manuscripts related to bloodless, patient blood management, and that's, I think, 9 times out of 10, the second or third sentence, maybe the first, is transfusion is a life-saving event, right? And we almost always start that way. So I learned this, of course, from my partner. Sorry.
Well, my internet here is very stable. Okay. Going up.
Okay.
Hey, please turn on your video. Go ahead, Sherry.
Yeah, so I can't take credit for this, but I learned this from from Dr. Shander, when we review those manuscripts, right, the first thing that we say when we see that comment is, can we please have the reference for that statement, right? Because if we're making a statement that strongly about any therapy, right, that fill in the blank, this therapy is life-saving, we don't make that assumption in science and in an evidence-based practice world, which we're all supposed to be following in medicine. We don't make assumptions, or we don't assume something is just, everybody just must know it, right? So really, where is that reference? Where is that reference from an academic perspective of transfusions save lives?
Yeah, I think in fairness, the phrase actually came from trying to get people to donate blood, 50 years ago. It wasn't that they were trying to claim that it saves lives. They were trying to stimulate people to donate blood. But a secondary distraction from this is that it has become commonplace to think of this. And, if you talk to patients in the hospital, they say, they're doing everything for grandma. They're even giving her blood. So there's this perception. So I don't think it was intended to start out as a claim of superiority. It was a marketing technique.
Absolutely, David. I mean, I completely agree with that. But I mean, it shows sort of the pervasiveness, right? Like that. I think the scientific writing, these are still human beings impacted by messaging that's out there, however the messaging comes. So, and again, no one, when they put that in a manuscript, has malintent. All of us, right, want to do the best we can for patients. But I think that starting from a place of assumption that, right, when the leading comment is, well, blood saves lives, everything else after that, it may have validity and it may be good science, but it almost seems like a little secondary, right? Because we've already made the assumption that blood is life-saving. So again, as Dr. Usoro said, I'm a little sensitive to articles where that, and again, I don't mean to insult any previous presenters at this webinar, because unfortunately I couldn't join earlier. I'm sure we had wonderful talks. So I hope maybe somebody said that here, maybe not, but we see it often. I think 9 times out of 10, when we first look at an article related to this, it still starts with that. So again, that's not discredit to those wonderful researchers and academicians and our colleagues and our friends, but we shouldn't necessarily start with that assumption. We should have the open mind to the science and what our data shows us.
Yeah, sure. And in my department, when people get up and they talk about the patient who needs blood, I always ask them, who is this patient who needs blood? Who needs hypoxia? Who needs immunomodulation? What exactly is the patient needing? Hypoxia or what? Because you need to be able to say scientifically, okay, when I give the patient blood, this is the benefit. We have outcome measures. So which outcome measure are you actually improving? And suddenly nobody's able to say what exactly they are improving, because science has shown that all the outcome measures get bad, they are worsened through transfusion. So we're just saying it out of habit. This patient needs blood. But the patient needs his or her own blood, not bank blood.
Indeed. What I find in reviewing a lot of records, and I think we've all seen this in so many hospitals, is right, and even at least in the United States, where we're using primarily computerized provider order entry, right, where for everything people are picking from a menu of things, what they're doing, why they're doing it. It's helpful, but sometimes it's reductionist a little bit. But most hospitals, right, that I think 99 hospitals out of 100 that I see, that first, at least for red cells, that first indication is symptomatic anemia, period, right? And it becomes such a loose, a loose way to do something as significant as a liquid organ transplant on a patient. And so, right, what are those symptoms? Okay, the patient is tired, the patient maybe is tachycardic, etc. But really have we looked at the other causes? And almost never, and I'm just reviewing records all the time. I mean, not as much as David, I'm sure, but reviewing records all the time. And, very rarely really do you ever see documentation either by nurses or by physicians or others about what happened to those symptoms that we were trying to correct, right? So if we gave it because the patient was symptomatic or tachycardic, what happened to the tachycardia? and did we look at the other causes, right? Was the patient in pain? Was the patient's fluid? Like those very, very basic things that we learn both as nurses and physicians sort of get overlooked, and we jump right to that. I reviewed a record just a few days ago, and I certainly won't mention the hospital, but I was having a conversation, an active conversation with an obstetrician, very competent person, I'm sure a very skilled surgeon. And he was talking about a 1-unit transfusion of red cells that he gave to a patient who was postpartum. She had a retained placenta. She went back to the operating room. Fortunately, she was okay. But when you read actually the note, because he described it as this patient was so ill and was so anemic and was so symptomatic that there was no question. So I actually pulled in the electronic record in a collegial way, but I said, let's just read through this. And it described that she just had her 4th baby. She had labored. She had a retained placenta. She went back to the OR. Her hemoglobin was 7. She was, her vital signs were rock solid. And here was the exact thing. The patient stated that she was tired. Discussed a transfusion with her, and she agreed to a 1-unit transfusion of blood. And so, again, I can just that case happens a million times a day, at least, probably all over the world. But he was able to check the box, right, to say symptomatic anemia, because that's such a sort of a loose indication. But we still are so, at least again, speaking in the United States, we're just so liberal even with the ordering process and what we're really asking our clinicians to document in terms of an intervention as serious as a blood component transplant. Hi, Neil. Nice to have you join us.
Hello.
I think the problem is stemmed from the fact that we have gotten away from chart review, and that we use dashboard metrics, and those dashboard metrics are usually laboratory-based decision-making. So for instance, if the hemoglobin is less than 7, patients will invariably get a transfusion, even if it's only 6.9. And so that is the problem, is that we're trying to do things more by dashboard metrics than to actually do an evaluation of the charts.
Yeah, agreed. Oh, thank you. I thank you for the reminder, Sarah. I'm sorry I didn't officially say thank you for joining us and for telling us all about your case. Then we got off into all the discussion, but we're so happy that you're well. And thank you for being with us.
Thank you very much.
Thank you very much, Sherry, and thank you for taking part in this discussion. Yeah, I think
if that can, and we're not done.
Yes.
When we are done, Sherry will let you know, please.
Okay.
Yeah, so I think that's again, I don't want to get off on a tangent, but David, I mean, again, congratulations on your recent publication that I think really highlighted that importance of getting into that clinical detail and really reviewing. I mean, how do you think that we do a better job of that overall? Because you're exactly right. I mean, I work with so many hospitals, and right. I mean, I think the argument, it's not an argument, but the discussion always, you can't change what you don't measure, and you do have to measure things, right? You do need metrics on things that we do. It can't be completely without that. But it's how do we reinforce the clinicians that, and when you're talking about transfusion and the reasons they give them, this is a much more nuanced decision. That's something that can be guided by just a number that, in a sense, even right, the studies that gave us those numbers were sort of arbitrary thresholds that were picked. Why is it 7 or why is it 8 or whatever someone might be working with? The initial approach to that given was arbitrary. So, and could talk about INRs as a whole other different ball of wax and platelets, lots of missing data, missing evidence, so to speak. Yet we don't treat it as a very nuanced decision. How do you think, David, that we're not a voice in the wilderness, saying that we have to actually go back to both good documentation and really good medicine. And then afterward, good review, not just numbers.
Well, I think the first thing that we need to do is we need to abandon the use of laboratory numbers as a criteria for transfusion. Just because the hemoglobin is less than 7 might be an indicator that the patient needs a transfusion, but a hemoglobin less than 7 is not an indicator of good blood management. There could have been a number of things that they did before the hemoglobin got less than 7 that would have prevented the transfusion in the first place. So the first thing we need to do is we need to abandon the use of these laboratory criteria. We should go to an attestation model that says, to the physician, I have taken all the steps that I think I need to have taken to prevent blood use, that the patient needs this blood transfusion to preserve organ function. And I think if you use that two-step approach, you'll have a much more thoughtful approach, because now you're putting it back on the physician. Oh, it isn't the hemoglobin less than 7, and I can now transfuse with impunity because there's a safe harbor, right? No one's going to look at this chart. So I think that's the first thing that we need to do.
I mean, I think it's an important point. It's the avoidability when I'm speaking to hospitals, and you know that, at least again in the States, that transfusion committee or that transfusion review process is very retrospective. They may look at a couple of cases. It's mostly, right, the fallouts that come out from whatever hemoglobin threshold or fibrinogen or whatever component you're looking at. But I always advise them to build in some way into the the review model the avoidability aspect of it, right? So again, I always tie it back to infection prevention because that's the model that works to me. But right, when there's whatever is happening in an institution with hospital-acquired infections, let's say, or infection rates, we don't spend all the time deciding, did you give the right antibiotic at the right time? We go backwards, right, to say what's happening with our hand washing and what's happening with our prophylaxis or what's happening with our sterile technique or whatever it may be, that looks at the avoidability of the infection, not just once it got there, did we choose the right thing to do it? So again, it's not exactly comparable, but I think that, right, we're still in a fairly primitive model with transfusion review. Almost every hospital has that. I mean, some are being prospective, even prospective, maybe, not always avoidability, but at least there's some intervention. But I think for the most part, I mean, David, you do this much more than I do. I think we're still seeing the traditional retrospective transfusion committees writing letters and sometimes having conversations.
Yeah, actually, there is no retrospective review being performed anymore. They have all gone to the default management. When you go to your transfusion committees, they talk about blood usage and complications and this and that, but there's no chart review being done. It's been replaced by prospective review. And, as a pathologist, I can tell you that the pathologist will call the clinician and say they're bleeding and they need blood. And they said, well, okay, well, they're bleeding, they need blood, but no one's checking to see how much bleeding they're having. And 90% of patients that have GI bleed are not actively bleeding when they're in the ER, but because they carry this horrific diagnosis of acute GI bleed, they almost invariably get transfused. So we just yesterday, I tabulated some data of charts that had gone through review and just got 1 unit of blood, and we segregated them by 0.5 gram per deciliter increments. And I won't take time to go over that right now, but it just shows that if patients get 1 unit of blood, 90% of the time they didn't need to get that single unit of blood. If they got 2 units of blood, 60% of the time they didn't need those 2 units of blood. So, and that's using moderately traditional levels of transfusion. I'm sure that Dr. Asaro would probably say these, or Dr. Shander would say, these patients didn't need blood, but trying to get people to look at traditional ways, even under traditional models, they didn't need blood.
Important point.
Yeah, so what we mean is that the patient needs
volume replacement, yes. But why use blood as a volume replacement? The patient needs iron because every unit of blood has 200 milligrams of iron. So why give iron in blood? You might as well give as IV iron, right? Because the body recognizes every other thing as foreign anyway and throws it out. So if you want the iron, the body can use, but you don't need to give it as a blood transfusion. You can give it as IV iron. If it is volume replacement, we can use crystalloids and colloids. I think we are blessed around here. We have Nigerian-made colloid that is fantastic. I won't mention the name so it won't be like I'm advertising. Fantastic, cheap, and it works. It can jack up. In fact, we have to be careful not to use it because it can just carry up the blood pressure. And now we're battling with the high blood pressure. So we use it sparingly. And once you've got the volume replacement, patient is still alive. There's no problem. It's just give IV iron and erythropoietin and take care of any electrolyte imbalance.
Thank you, Nat.
So I think what I see in the United States is that a lot of pushback comes from the pharmacy department because this is going to greatly increase their budget. And so it's a battle. And so that's why it's important to get the hospital involved and make a global decision that, yes, it's going to increase the pharmacy budget, but it will decrease the blood bank budget and it will be better for everyone.
Oh, sorry, please.
Yeah, the advantage we have in Nigeria here is that somehow, even though it's not an advantage, people pay out of pocket. Then the health insurance here is not too good. It's not very efficient. The challenge we have mainly is when the patient is symptomatic. Because I know most of the time, you need to support their respiration to be able to get, to give them adequate oxygen to the tissue. So the challenge, I know that most of the time, the physicians, especially if the person is not dual weakness, will rush to give the blood to stabilize the person. But ideally, if we have facilities for those that are dual weakness, which you know that blood transfusion is not an option, they will try to tie them off the initial point while they build them up with intravenous iron and erythropoietin. But it's not usually very funny at all when they are symptomatic, especially when we have those that have hemoglobin as low as 4 grams or 3 grams. It usually takes about 3 to 4 days for them to build up to be stabilized. And during that time, we nearly have to support their respiration to take off the work of breathing from them and give them adequate oxygenation.
Yes, that's what I learned from the anesthesiologist. That's why we have that pillar about ensuring tissue oxygenation. That is the third pillar. We created a pillar differently for it because it's so important. And if you want to support oxygenation, one thing you mustn't do is to transfuse because scientific evidence is that it causes hypoxia. So in our setting, we have taken care of patients with hemoglobin of 1 point something, 2, 3. Not a single one have we lost. So if we take care of that, make sure the patient is on oxygen. That helps. And then ensure that if it was hemorrhagic, by the way, I'm sure we the professionals, we've all seen the paper in Lancet from UK that was comparing giving blood to patients in hemorrhagic shock compared with normal saline. You can imagine, Professor Ilori is chairman of our ethical committee, and I'm sure a few years ago, nobody would give ethical approval for such a study because it would be like they're trying to kill the patients, comparing normal saline with blood transfusion in hemorrhagic shock. But they did it. They gave ethical approval, and that already tells us that the efficacy of blood transfusion is in doubt. And what came out of the study?
there was no superiority of blood transfusion or blood products over normal saline. So I think that was a very generous conclusion. It is more likely that if they look closely, they'll find that there's worse outcome, because there's an earlier paper showing that in trauma with shock, transfusion leads to worse outcomes.
So I think if Dr. Ilori, if your connection is good now, it seems to be your internet is working well. Let's move back to you, because we didn't hear as much as we wanted yet from you. Tell us about a little bit, if you can. Oh, she disappeared. Is your connection good? Your internet is okay?
Are you referring to me?
Yeah, can you hear us well now, Dr. Ilori?
Yeah.
Okay.
Yes, I can
Okay.
hear you.
Okay, good. I know you had a little connection issue. So tell us a little bit more, if you can, about how you got involved in Bloodless Care and your thoughts, because we're wrapping up here specifically on cancer patients on oncology. So help us hear more about your experience, please.
Actually, I started getting involved with Bloodless Medicine and Surgery when I was a resident doctor. Usually when we have joint weakness, people to come in for surgery, everybody will hands up, so they don't want problem. I said, okay, let us try. And that is why I started getting involved with Bloodless Medicine and Surgery. I started talking to my colleagues. I said that even though I'm not a Bloodless Medicine and Surgery, or I don't support it, sort of, but I always prefer patient autonomy. And I've always, since I started practicing as an anesthetist, I always make sure that blood is the last option. I will do everything possible to make the patient stable until when I find out that it is not possible again, that's when I give blood. But often, the little experience I have with oncology people, even though it's not documented, I used to find out that some of those, usually people that have intestinal pathology, cancers, usually cancer of the head of pancreas, I used to find out that most of the ones that we transfuse, the post-op period used to be very, very turbulent. They will be the morbidity will be so bad, they will be delayed in wound healing, and sometimes 10 days, 14 days post-op, the wound has not healed. Sometimes some of them succumb. So I started wondering, is it the blood transfusion that really caused it? Before I started reading, to find out that the blood transfusion caused immunomodulation. And we all know that if you transfuse, if you cross-match, for example, have a major surgery, you cross-match maybe about 4 units of blood to give to a patient. The first, if you give 2 units, maybe 3 or 4 days, you cannot go and take the other 2 units that is remaining to come and transfuse the patient. Because if you do that, there's going to be a lot of reaction. So it means that the blood itself has some immunomodulation, which affects the patient's system and sort of affect their immunity. I think from that, my experience, I usually for cancer patients, I try it as much as possible, if it is possible, to build them up depending on the stage of cancer. And if it's possible that post-op, we try to build them up. The issue that we don't really have facilities to monitor, because if we have facilities to monitor to their therapy, whether there is any problem in maybe like the folic acid, they said, okay, it increases the tumor recurrence, or the erythropoietin. So, but we just give and we watch, not really, what I call it, just clinically watching the patient. And sometimes we find out that they do quite well.
Wonderful. No, thank you. And I've heard so many similar stories from clinicians that were, I think, for many years just thinking they were seeing something different in the transfused versus non-transfused patients. But we know that now there's thanks to Neil and others, solid data as to why we were seeing something different in patients who are receiving blood components, not just anecdotal, in oncology and other areas certainly too. So in terms of our next generations of clinicians, Professor Ilori, How do we influence these principles, influence these younger folks or training folks, whatever age they are, in the principles of bloodless surgery? How do we impact curriculum so that our future generations don't see this on the periphery, but see this as really the right way to approach patients?
Well, Dr. Oso has been trying to see how it can be put into the medical students' curriculum. And currently, for the medical students, I think in their first clinical year, they are being taught the principles of blood transfusion. And they are being told that blood is not an option, but you try as much as possible to screen your patient for anemia as soon as they come in. We have been advocating that every patient, because naturally here in our environment, people don't come to the hospital as to just say they come in for checkup. And before they come, they must have gone to so many places, and hospital is usually the last option. We are advocating that as they come, that's the opportunity to screen them for anemia, whether they're coming in for surgery or coming in for ordinary illness. We should screen them for anemia and treat them. We have a lot of parasitic infestation. People walk barefooted, hookworm is there, malaria is there. There are so many parasites that are causing anemia. So generally, like now, we are facing there's a lot of starvation and hardship because of the insecurity in Nigeria. So it's an opportunity that as the patient have opportunity to come to the hospital, we screen them for anemia and also try to treat the anemia so that in case they come down with any illness that requires surgical intervention or any illness that causes bleeding, their hemoglobin will be well taken care of. As for green vegetables, we have a lot of green vegetables here, which is available for people to eat. Nutritional support, education, and then general making the screening to be cheap, because if it is expensive, people will not be able to do it. But it's good now that the National Health Insurance Scheme, the food blood count is almost taking care of that. But at the same time, we need to do more in awareness and education of the masses on how to live a healthy living, so that they reduce infestation and don't come out with anemia when they are sick.
I know we have a lot more thoughts and ideas, but I think we're at time. We're a minute beyond our time. So I think I'm tasked to hand it back over to Dr. Inaku or to Sandra.
Is Dr. Inaku still having issues with his microphone?
Okay. Sorry.
I think so. Sandra, you can go on.
Okay. Kenneth, I wasn't sure if you were able to speak, but if not,
Hear me now?
yes.
I hear you.
I think we were supposed to do a preview of tomorrow's program. It has been a very long day, and I think we've really had so much. We want to thank all those that have participated.
Sorry, Ken, we can't hear you. Let Sandy handle this.
Okay, please.
Okay. Sorry about that, Kenneth. I do want to say thank you also real quick to Sherry and her team there for all the discussion and experiences and really encouraging thoughts and thought-provoking thoughts as well, because really these are things that we're still challenged with and we'll continue to work through. So we do want to talk about tomorrow real quick. Tomorrow we will have a couple of good presentations still. Thank you for bringing that up. Our moderators will be Dr. David Jadwin and Abigail Ibarra. So we're looking forward to hearing from you tomorrow, as well as our presentations, Bloodless Care in Urology with Oluwatomo Odutala Oyewu, doctor. And also we're going to have Dr. John Waters and his presentation as well. So we look forward to those tomorrow. Again, thank you everybody for joining us today. Our panelists that we had, definitely Dr. Simotowu for giving his part. And as far as the blood loss in cancer surgery for better outcomes, Cassandra Church, we appreciated your part very much for nursing and the profession and our bond and relationship with our patients and empowering them, and as well as Sherry. So thanks again, everyone. If there's anything else to contribute, Dr. Soru or
yes, please.
Chris?
So I'm going to put, let's be in gallery view, and as all of us should turn on our cameras, and everybody should take pictures. So please turn on your cameras. And turn on your smile as well. So after 2, 1, 2, smile. And keep smiling. As the last person taking the picture, all of us, please take a screenshot.
I've taken, but it's not gallery view.
Okay. No, we need the gallery view so that I can be there.
You have to put on the gallery view.
I thought I did.
No, sir.
I'm so sorry.
I'm not a co-host, so I couldn't do it from here as I did before.
Today has been tough.
Well, I put on the gallery view now.
Yeah, you can
Oh,
do
no. It's still not gallery here.
It's not the gallery here.
Okay. Okay.
Okay, so I should smile again. I don't smile all the time, you know.
Abigail, put on your camera.
Oh, Abigail, maybe at work.
Okay.
She's in nephrology. All right. Okay. So back to Sandy to say goodbye to us.
Okay, the hardest part. We want to thank everybody again for coming. And also, I just wanted to mention, apologize if we weren't able to get to everybody's questions and comments today. There were so many. We had good feedback and a lot of support. Tomorrow, there's still possibly time to bring up some of these questions again that we can answer. And we certainly do want to leave everybody satisfied, you know, with what they need to know before going off. And so that's what this whole conference is about, is, you know, empowering all of us really, so that we can go out there and do our jobs and be advocates and feel supported. So thank you all speakers and all the attendees that were part of the program today. And we look forward to tomorrow, same time, with our speakers and our panelists and all of us. So with all that, I'll leave everyone off today. Have a good rest of the day, and we'll see you tomorrow.
Thank you. Thank you, everybody.
Thank you.
Thank you.
Bye.
Thank you. Thank you so much.
Thank you.